Namaste, myself TRIVENI KHURANA, Assistant Professor, Faculty Physiotherapy and Diagnostics. Today we are going to discuss about continuation of history and examination of PAEDS. Restricted mobility of spine and thoracic cage may be present in ankylosing spondylitis or severe systemic onset juvenile rheumatoid arthritis or juvenile idiopathic arthritis. Detailed information about home management and the use and frequency of equipment must be included in the history. Exercise dyspnea may be a sign of pulmonary compromise or deconditioning with the high energy cost of physical activities in children with some motor disabilities. Scoliosis may exacerbate respiratory disease in some of these children. Cardiac decompensation with right-sided failure, a potential complication of pulmonary dysfunction, is more likely to occur in older children or young adults with previously mentioned disabilities. Myopathic conduction defect and arrhythmias are often symptom-free in absence of heart failure. Consultations with pulmonary or cardiology specialists should be arranged when history reveals suspicious symptoms. Visual and hearing impairments are more frequent in those with childhood disabilities. Inquiry about these aspects of function is a part of the history. Regular hearing and visual assessments are required. Prenatal infections, anoxic or infectious encephalopathy, metabolic diseases, meningitis, hydrocephalus, and head injury warrant exploration of visual and auditory function. Like all children, youngsters with disabilities are prone to a variety of childhood illness. In some cases, however, acute symptoms and febrile illness may be directly related to complications of a specific disability. Vomiting, headache, irritability, or lethargy may be prodromal signs of decompensating hydrocephalus in spina bifida, cerebral palsy, or an incurrent unrelated illness. Recurrent headaches are also a manifestation of autonomic dysreflexia in spinal cord injury. Fever may represent central hyperpyrexia in several head injury or hypothermia due to pseudomotor paralysis in high thoracic spinal cord injury. However, these diagnoses can be made only after other causes of fever have been excluded. In those with a neurogenic bladder, urinary tract infection should always be investigated as a possible cause of febrile illness. A history of usual pattern of the amount and frequency of voiding is essential in neurogenic bladder dysfunction. Systematic daily recording is a guide for bladder training. Fluid intake in accordance with pediatric norms needs to be monitored at home, and records of both bladder and bowel stool should be available on the medical visit. Immunization history is a part of all pediatric visits. The child in good health may not have received the recommended vaccinations because of excessive concern on the part of the family or pediatrician, or the child may have been ill when scheduled for immunization. Now, moving towards history of behavior. The examiner should ask about the child's behavior in terms of temperament and personality. The parents may state that the child was always a good baby, but this report may mean that the youngsters never cried and slept more than expected for his or her age. In other cases, parents may report excessive crying and restlessness both while the child is awake and asleep. Some children may show excessive mood swings from lethargy to hyperactivity, whereas others are even-tempered and react appropriately. One should ask the parents whether the child is friendly, outgoing, and sociable, or shy and withdrawn, particularly in group situations. Parental guidance may be needed to encourage interactive behavior by the child. compliance or problems with obedience, daily activity level, attention span, sleeping and eating habits, and special interests and dislikes are revealing information. Separation from the parent may be a problem for some children with disability. The parents may be uncomfortable to leave the child with relatives or other caretakers. In this context, it is important to point out the need and possible approaches to foster the child's independence. Now, moving toward educational and social history. Very young children may be enrolled in an early intervention program, either home or center based. Frequency, length of session, components of training, the child's tolerance and cooperation in the program, and its effectiveness as perceived by the parents should be clarified. The same applies when the slightly older child attends a preschool program. In school-age children, information about the types of class, mainstream, integrated or special education is important. Academic expectations are different in each of these educational pathways and should be taken into consideration when report card grades are interpreted. Individualized education program, meetings, and environmental accommodations are other pertinent details. The child may have special interests and strengths that should be further developed, or difficulties in certain subjects which may require additional help and adjustments of individualized educational program. Review of educational status is a consistent part of follow-up visits, and assistance should be offered when problems arise, including cognitive and neuropsychological testing. Opportunities to meet and play with other children in addition to school or home contacts, visits and sleepovers with friends, and participation in various recreational activities are formative experiences that prepare all youngsters for social functioning and adulthood too. Asking the parents to describe the child's daily schedule, including regular and occasional activities on weekdays and weekends, yield a valuable insight into these aspects of the entire family's lifestyle. Time spent in school, therapy, home, play, and leisure activities with family member, friends, or alone should be noted. Housing, employment of parents, siblings, and their ages, and social support of the family provide further understanding of the physical and social environment. Some families with a disabled child experience social isolation. Information about or referral to community resources may be helpful for many families. This may include recreational and sports training and teams, theatre, music, and social outings. Now moving towards family history. In motor or other developmental disabilities, a detailed family history must be obtained to explore the possibility of a genetic disease. Health and function of the parents, siblings, and other family members on the maternal and paternal sides should be explored through several preceding generations. One should ask specifically whether there are other children in the family with the developmental delay or adults with non-motor disability, limb deficiency, or other malformations. Historical information is at times incomplete until further questioning brings to light additional facts. Family album and pictures of relatives may be helpful to detect dysmorphic facial or other features. Consanguinity is an increased risk for genetic disease, especially diseases with an autosomal recessive inheritance pattern. In some autosomal dominant conditions, mild variants of a disease may be missed until a thorough investigation of suspected family member is carried out, including congenital myotonic dystrophy and facioscapulohumeral dystrophy. In X-linked conditions, affected males typically have a maternal family history. Diseases with multifactorial inheritance such as spina bifida are complex and may or may not have a non-family history. Referral for genetic workup is necessary wherever there is a possibility of a genetic condition. Pregnant mothers of affected children should be referred for genetic counseling. Prenatal diagnostic testing is available. Now, the studies. Radiographic imaging is useful for a variety of children. For those with bone abnormalities, plain films will be helpful. For those with a brain involvement, computed tomography and MRIs may add to the diagnostic specificity. Electrodiagnostic testing is helpful in those with brachial plexus palsy or other nerve or muscle lesions. Electrodiagnosis is used less as genetic evaluations become much more specific for muscle and nerve diseases. Chromosomal and DNA testing are available for many diagnoses. Prenatal chromosomal testing, fetal DNA from the maternal bloodstream, newborn screening, and carrier screening are all available with advances in techniques continuing. Now moving towards examination. Under examination, first is observation. The examination begins as soon as the family and child enter the examination room, before the child is actually touched or asked to perform. Sometimes it may be the most informative phase of the examination. Specific behaviors to observe and note include reactions to separation from the parents, especially in young children, apparent visual and auditory awareness, temperament, calm or hyperactive, compliant or challenging, spontaneous explorations and interest in toys, games or books in the room, style, concentration, attention span or distractibility during play, level and manner of motor activities, attempts to engage the parents and examiner in conversation, vocabulary, complexity of language and quality of speech, and interaction with parents or examiner that appropriate, shy or demanding. Observing the parents' response and their way of handling the child's behavior are also revealing. Now, examination by age. For infants and young children, the examiner must create an atmosphere of trust. Friendly advances during history taking or while the child is at play allay initial fears and anxiety. At this age, most, if not all, of the examination can be accomplished with the child in the parent's lap if the child remains fearful. Interactive play in this phase of examination can incorporate developmental testing by offering toys for grasping or resins to test pincer grasp. Blowing bubbles makes most youngsters comfortable and happy, and one can assess their visual motor coordination as they reach to pop them. Balls are also extremely versatile and non-threatening items to engage a child in his or her exam in a variety of ways. Hearing, vision, cranial nerves, and postural abnormalities also can be observed. As the parent gradually undresses the child, gentle touch and tickling or funny sounds with a smile help to maintain relaxation and to facilitate hands-on examination. Inspection and palpation of body parts and gentle movements to examine tone are performed at this point. The examiner should be prepared to intrusive if the child shows increasing anxiety. The actual hands-on examination, consisting of bodily handling and manipulation, is the last stage. Anxiety-provoking or painful tests are deferred to the end. If the examination requires placement of the child on a table, the parent can sit at the end and let the child's head rest on his or her lap. With anxious children, performance of gross motor activities such as sitting, crawling, standing, or walking also can be conducted with the family's help. One should note the quality of movements, postures, and weakness in coordination, asymmetry, or reflex abnormalities that reflect a motor deficit. Range of motion, deep tendon reflex, or primitive reflex that need physical manipulation should be examined after evaluation of active mobility. Tests that require instrumentation such as sensation, fundoscopy, otoscopy, and oral function conclude the examination. Thank you.